Greetings everyone. Welcome to the 125th session of the online Optom Learning Series, or OOLS. And for today's session, we have with us Dr. Liat Gantz. Dr. Gantz is an Israeli optometrist with a Bachelor of Optometry and a minor BSc in Computer Science from the Bar Ilan University in Israel. She also achieved her PhD in Vision Science in the field of psychophysics of depth perception from the University of Houston College of Optometry in Texas, USA in the year 2009. She also went ahead to complete her postdoc in the field of clinical electrophysiology and a subsequent postdoc in the field of electropsychophysics of depth perception. Currently, she is a senior lecturer in optometry and the director for the Masters of Optometry program at the Hadassah Academic College in Jerusalem, Israel. She is fond of binocular vision. She teaches binocular vision as well as she also teaches a part of vision science. She's an active researcher in the field of depth perception and clinical optometry with over 15 peer-reviewed publications, and has contributed chapters to the Opticians and Optometry Today, continued educational journals, which is based in the UK. She is a fellow of both the American Academy of Optometry and also the European Academy of Optometry. She is also an expert reviewer to several scientific journals in the field of vision research. And today, Dr. Gantz is here to talk to us about a very interesting topic. I guess binocular vision is something which needs passion to teach. To be really honest, you need to understand to teach. And prisms is something which we would encounter very frequently, I guess, but because of the lack of experience or knowledge, we tend to neglect. And she's trying to make it easy in letting us understand how should we go about prescribing prisms based on the evidence. So welcome, Dr. Gantz, onto our platform. And let me just leave the screen time to you.
Thank you so much. Thank you to OOLS for inviting me to talk today. Hopefully this lecture will give you the background that you need to prescribe prisms and also to figure out when to prescribe prisms. So let's start in the beginning. I'm a very big fan of evidence-based practice. I'm aware that lots of clinicians will say something like, and I had a clinician say to me once, wow, I prescribe these scleral lenses. They're amazing. All my patients love them. I got all these letters from my patients thanking me for saving their sight. And that clinician really did have several letters of appreciation from patients. But when we went through the patient log and recorded how many had been fit with those lenses and how many were continuing to wear those lenses successfully, the percentages were quite low. So oftentimes we have some kind of a bias when we're seeing patients that are super happy and are writing thank you letters to us. And we don't always look at the numbers. And so that's why I'm a huge fan of evidence-based practice. And because I'm a huge fan of evidence-based practice, I brought you this paper by Lyle Gray talking about the prescribing of prisms in clinical practice. And the take-home message, the key points of this paper are the following. Prescribing prisms is really based on the clinician's discretion. There's no real set of definitive rules. It really does depend on you. There are several varying approaches to prescribing prisms, but every single clinician before prescribing a prism should verify that there's no prism adaptation, also known as Vergence Adaptation. We only treat patients with prisms when there really are binocular vision anomalies, and we only treat with prisms when it's indicated. And what we're going to do throughout our next hour together is kind of go through each and every single one of these points and define them so that they're very clear to you. So if nothing makes sense to you now, it's okay. It will make sense shortly. So what is evidence-based practice, EBP? Because, Americans like acronyms. So evidence-based practice is basically a combination of research evidence of what the patient really needs and wants, and also clinical expertise. So just like the previous paper said, prescribing prisms is dependent on the clinician's discretion. We cannot take lightly the clinical experience of clinicians who have been prescribing and kind of like over time have learned when to do it and how to do it. And so we have to take that into account as well when we talk about prescribing prisms. So let's start with prism Vergence adaptation. And I'll go back to the key points that we talked about. Clinician discretion, there's several approaches which we will discuss. But the third point was verify no prism Vergence adaptation. So what is prism Vergence adaptation? And let's start by defining what is adaptation. Adaptation is a fundamental property of the nervous system. Every time an organism has some kind of change in the environment or an internal change, that organism, in order to survive, has to adapt or reconfigure itself or its sensory motor processing. So adaptation enables organisms to survive. And it turns out that also the human eye, when a prism is put in front of the human eye also responds to the prism by adaptation. Or let me say it this way, normal visual systems, they respond to prisms by adaptation. And what does adaptation to prism mean? Or what does Vergence adaptation mean? I brought you this graph, which this graph is basically something that's been shown over and over and over again every time a prism is put in front of the eye. But it was originally brought out, the whole idea of prism adaptation, by von Helmholtz in 1867. And this is actually his publication from 1867 in German. And what we see here in this graph, you see this y-axis? This is the dissociated Phoria measured in prism diopters. That's what you would measure in either Von Graph or Maddox rod, or the Maddox with a Thornton card, or the Maddox wing, or even with the prism neutralized cover test. So that is your dissociated Phoria, the position of your eyes when there's no demand for fusion. So when you do a cover test, you're canceling one eye. So there's no longer a demand for fusion. And the eye under the cover is allowed to go wherever it wants. When we measure that, we measure the dissociated Phoria. So what you would do is you would put a prism in front of your patient's eye, and you would measure the dissociated Phoria. And what you would notice is as soon as you put the prism in front of the eye automatically responds to the prism. So if you put 5 prism diopters in front of the eye, you will measure now a 5 prism diopter dissociated Phoria, okay, in a person that has no Phoria. And then over time, what you will see, if you will continue to measure the dissociated Phoria, approximately every minute or every 2 minutes, in this same person with normal binocular vision, you will see that the dissociated Phoria slowly but surely starts to reduce and revert back to baseline. So let me just say that again, in case that was a little bit too quick. In a patient with normal binocular vision that has no Phoria, and then you stick a prism in front of that patient's eye, and you start measuring their dissociated Phoria. As soon as you put that prism in front of the eye, that prism will cause a change in the dissociated Phoria. But if you keep that prism in front of the eye starts to adapt. And so it starts to revert back to its baseline. So if originally there was no Phoria, slowly but surely, over time, the visual system will start to revert back to no Phoria. And that's called prism Vergence adaptation. This is the part of the adaptation, this part of the curve. However, as soon as you remove the prism, all of a sudden, boom, you'll have a huge change in the Phoria because the system has already adapted to the prism and kind of swallowed it. And now when you take the prism out, you'll be measuring Phoria in exactly the opposite direction. And also then, over time, every minute or two, if you continue to measure the dissociated Phoria of that visual system, slowly but surely, also that Phoria will go back and revert back to baseline. So that's exactly what was seen already in 1867, that the visual system adapts to the presence of the prism. No matter which prism you put in front of the eye will revert back to its baseline dissociated Phoria condition. But in order for that to happen, as I said earlier, this will only happen in visual systems that are normal. Visual systems that are not normal are a completely different story. So if you have a patient that demonstrates prism adaptation, that is obviously a patient that it would not be a good idea to give them prisms. And why is that? Because if you give that patient a prism, let's say to cancel their Phoria. So if that patient has 5 prism diopters of an exophoria, and you decide to put a 5 prism diopter prism that is based in to cancel that Phoria, really, as soon as you put that prism in front of the eye, you'll measure orthophoria. But if that visual system adapts to the prism, over time, the Phoria will revert back to 5 prism diopters exophoria. And therefore, giving that patient a prism in order to cancel their Phoria is not a good idea. So what does it look like when a patient does not demonstrate prism adaptation? So I've drawn that for you here. Here we have the same graph just from a different study. You see the dissociated Phoria on the y-axis. And then what you see here is the curve of adaptation and the curve of the recovery. And what I drew for you here in blue is what happens when there's no adaptation. A patient that has a faulty binocular visual system that was given a particular amount of prisms that caused a 5 prism diopter exophoria. If that visual system does not adapt, no matter how much time passes, and this is minutes on the x-axis, no matter how much time passes, that patient will consistently measure 5 prism diopters exophoria. And that's an example of a patient that does not show Vergence adaptation and can be prescribed prisms. So here's my first clinical pearl to the clinicians here, or to the upcoming clinicians, the optometry students here. If you want to prescribe a prism to your patient, you must do the following first. Measure your patient's dissociated Phoria already in the clinic. And you could do that in any one of the methods that you typically measure, whether it be cover test or Van Graaf or Maddox rod or Maddox ring or Maddox with a Thornton. Then you place the prism that you want to prescribe in a trial frame, obviously with the patient's refraction. Then you take the patient out to the waiting room and you ask the patient to please sit down and read some text. You can also ask the patient to not just read the text, but also kind of walk around. I don't know if most of the stores in the setting where you work or where you practice or where you're going to work and practice are stores that are in shopping areas, or they're stores that are in a place that allows a little bit of walking around, but have them both read as well as walk around. Then after 15 to 20 minutes, bring the patient back into the room, remeasure their dissociated Phoria, and ask them how they subjectively feel having that prism in place. Did they feel better when they were reading? Did they feel better as they were walking around? If you see that the dissociated Phoria is reduced appropriately, meaning the dissociated Phoria did not revert back to what you had originally measured, then great, you can prescribe prism. However, if the dissociated Phoria reverts back to what you measured previously, despite the fact that there's a prism in front of your patient's eye, do not prescribe. This patient has demonstrated prism Vergence adaptation. So let's go back to the key points before we move forward. So we said clinician discretion, we said varying approaches, we said to verify that there's no prism adaptation, and hopefully I've now described to you what is meant by prism Vergence adaptation. And now I want to move on to the fourth rule, the fourth point. Treat only in the presence of binocular vision anomalies. So let's go through the binocular vision anomalies and try to figure out which ones are the ones in which prism is indicated. So we can, I'm only going to concentrate today on binocular vision Vergence anomalies, Vergence of the muscles. So we have basically 3 different categories of binocular vision Vergence anomalies. The first category is patients that have similar Phorias at distance and at near. They have a normal ACA ratio, accommodative convergence to accommodative ratio, and that the disorder only bothers them at near. So they have discomfort, ocular discomfort, headaches and complaints, and general asthenopia, mainly at near. The second category is patients whose distance phoria is greater than their near phoria. Their ACA ratio is either high or low. It's not normal. If it's high, these patients have an excess. And if it's low, they have an insufficiency. And these patients have a distance disorder. In other words, they have complaints, they have discomfort, they have headaches, they have blur, diplopia, and general asthenopia, mainly for distance viewing. The third category is the category in which the near phoria is higher than the distance phoria. The ACA can be either high or low. It's not normal. If it's high, the patient is diagnosed with excess. And if it's low, the patient is diagnosed with insufficiency. And this is a near disorder, meaning the majority of the complaints are for near view. Similar phoria at distance and near, normal ACA, near disorder. This includes basic exophoria and basic esophoria. Basic exophoria, as we said earlier, is a near disorder. This means that the symptoms are related to the use of the eyes, either for reading or other near tasks. And you have a whole list here, and we've already mentioned the majority of them. As I said before, the distance and the near phoria are approximately the same, but this is called a basic exophoria, which means that the near phoria is exo and the distance phoria is exo. Now here, I'm going to say we're talking about large numbers, okay? Not 4, not 3. We're talking about, 10, 12, 15, 20 prism diopters of an exophoria. However, when we say that the phorias are equal, it's within a particular range, right? Because when you measure a patient, you can measure them now and then measure them in 5 minutes, and you may not get exactly the same reading. A person can have 15 exophoria now and then measure them in 5 minutes and it'll be 16. So we call the phoria at near and distance the same phoria if it's within a range of approximately 4 prism diopters. Then we consider it the same amount of phoria. And then the ACA in this disorder is normal, which means approximately 4 to 1. Now, obviously, if it's 3 to 1 or 5 to 1, I'm not going to take anybody to court. But if it's 1, then that's a low ACA. And if it's 10, then that's a high ACA. So a patient that has complaints at near, has similar but high exophoria at distance and near, and has a normal ACA is diagnosed as having basic exophoria. Now, this patient that has complaints, you want to help this patient. How can we help a patient whose eyes are diverging? Do you want to write to me in the chat if anybody wants to write what you would do with a patient whose eyes are divergent? I mean, we could help with prisms, right? We could put in base in prisms, and the base in prisms are apex out, right? Base in, apex out. The object goes out. That's an option. Another option, as one of you has just written for me, is vision therapy. So we have to think about whether we want to do prisms or we want to do vision therapy. So I'll tell you what the general rule of thumb is. Vision therapy is very, very efficient and has been shown as efficient in numerous studies to teach convergence exercises. In other words, training the visual system to converge is relatively easy to do and it's efficient. So before we run to prescribe prisms, in a patient with basic exophoria, we're probably going to prescribe vision therapy. We'll only revert to prisms, we'll only prescribe prisms if we see that the vision therapy is ineffective. So basic exophoria is not a case in which prisms will be our first choice. So I'm going back to the categories. We said similar phoria at distance and near, normal ACA, and the near disorder, and we talked about basic exo. Let's move on and look at the basic ESO. Basic ESO follows the same pattern of rules. It's a near disorder, and here we have some symptoms here, long-standing headaches, eye strain, blurred vision, and this is at near. The near phoria and the distance phoria are approximately the same within a range of 4 prism diopters, but it's called basic esophoria because the patient has an esophoria both at distance and at near. And again, I'm just reiterating, we're talking about large numbers. It's not a 2 prism diopter esophoria. It's like a 20 prism diopter esophoria. And again, the ACA is normal. In this case, it's an esophoria, so the eyes are convergent. And what we need to do is we need to treat the patient And there's two ways in which we could treat this patient. What are the two ways in which we could treat the patient? Actually, there's three. Okay, so the first option is prisms. And in a minute, we'll get to that. And you're right, it's base out prisms. Base out means apex in. So it's bringing the object to where the eyes are. Great. Another option is, of course, refractive error correction, added plus, exactly. So since this is a near disorder, it's quite common to prescribe reading spectacles for near work. And so this patient who might have issues at near can be prescribed reading glasses. Would reading glasses assist this patient? So let's think about that. When we prescribe reading glasses, we're prescribing plus lenses. Plus lenses means that the patient has to release accommodation. And when the patient releases accommodation, together with the accommodation, another Vergence activity is coupled. What do we get every time we activate accommodation? We also get accommodative convergence. So if we put plus lenses in front of the patient's eye, we make the patient relax there and release accommodation. We're also releasing accommodative convergence. In other words, we're getting divergence. So that could be a great solution for this patient. Again, you have to keep into account that the ACA is only 4/1. So the maximum release you can get, usually how much do you give when you prescribe a near prescription? How much is your added plus for near? Like the maximum addition you could give a patient. I mean, it's not going to be 5 diopters, right? How much is it going to be? Anywhere between 2 and 3. So if I'm giving a +2 and the patient has a 4/1 ACA ratio, and I only gave 2, the patient is only releasing 8 prism diopters of accommodative convergence. So depending on how much the Phoria is that's bothering this patient, 8 may or may not be enough. So that's also something to keep in mind. So we said prisms, and we said reading glasses. And the third option that the optometrist has is vision therapy. Vision therapy, as I said earlier, is really, really effective when we do convergent exercises. The problem is that the patient here has a basic esophoria. In other words, the patient's eyes are too converged. So this patient, in order to treat him with vision therapy, we have to train the patient to do divergence. And unfortunately, vision therapy for divergence is not very effective. It could happen, I'm not saying it can't, but it's not as effective as convergence exercises. Therefore, in the case of basic esophoria, because the ACA is normal and not very high, and the maximum plus that I can prescribe for near is +2.5, maybe +3, and I'm only going to get something like, if it's 4/1 and I'm giving a +3, I'll get 12 prism diopters of convergence, accommodative convergence, divergence, accommodative divergence. It may or may not be sufficient for this patient, and therefore, the number one choice for patients with basic esophoria is actually, as you wrote earlier, is to give base out prisms. So this is a case in which we would opt to prescribe prisms for the patient. So I'm going back to my list of binocular vision disorders. We talked about basic exophoria, in which vision therapy is the most likely solution. And we talked about basic esophoria, in which base out prisms is the optimal solution. Now let's look at the next two. These are disorders in which the distance phoria is higher than the near phoria. The ACA can be either high or low, and it's a distance disorder. And these are divergence insufficiency esophoria and divergence excess exophoria. So let's look at those two. Divergence insufficiency. Because it's a distance disorder, the symptoms are long-standing intermittent diplopia at distance, not at near. Diplopia worsens when the patient is tired, headaches, eye strain, even nausea, dizziness, even train and car sickness because you're looking at the distance, you're not typically reading. Blurred vision, difficulty focusing from far to near. So these are the kind of symptoms you might encounter. And here you'll find, because it's divergence insufficiency, you don't have enough divergence. In other words, we have an esophoria. And because this is a distance disorder, the distance esophoria is greater than the near esophoria. Oh, I have that flipped on the slide. I need to fix that. An insufficiency is called insufficiency because you don't have enough divergence. And because you don't have enough divergence, it also goes hand in hand with a very low ACA. It's insufficient, so it's low. So in this case, when a person does not have enough divergence, again, let's look at all the options we can give our patient. Can we give near reading glasses to this patient? Will that help? Probably not, because this is a distance disorder. In fact, if we do decide to prescribe something, we may want to give 2 pairs of glasses for the patient, one for distance and one for near. So reading glasses are not going to solve this issue. And also reading glasses, they cause the eyes to diverge. So it might be helpful, but not for distance. We're not going to give plus for distance. It's too blurry. Another option that we have is vision therapy. Can we do vision therapy on this patient? Yes or no? I mean, we could try it. The problem is that vision therapy is not very effective when we want to teach the patient to diverge. Vision therapy is more effective when we want to do convergence. So vision therapy is not a very good alternative for this patient. The best alternative for divergence insufficiency patients is to give them base out prisms. Okay, so we have a large esophoria, eyes are convergent, especially at distance. It's best to give prisms. In this case, the distance esophoria is higher than the near esophoria. And so it's a little bit tricky. Either we find a low amount of prisms that are good for near and that will also help the patient for distance, or we prescribe a separate pair of glasses, spectacles for distance, and a separate pair for near, in which we have different varying amount of prisms, or we prescribe bifocal lenses, bifocal glasses, in which we put the prisms in the distance portion and we don't put the prisms in the near portion. Because again, divergence insufficiency is a distance disorder. So we talked about the divergence insufficiency esophoria, in which the best solution for the patient is base out prisms. And now let's look at the next one, divergence excess exophoria. So divergence excess exophoria is a distance disorder. The near exophoria is smaller than the distance exophoria. And the ACA is very, very, very high. In this case, the eyes are too divergent, especially at distance. What is the best solution that we can offer the patient who has varying amount of prisms at distance and near, and the eyes are too diverged at distance? If the eyes are too diverged, the solution that we want to give is convergence exercises. And we know that convergence exercises are the most effective solution, or the best vision therapy is for convergence. So this is a good plan for this patient. So I'm just going to go back to all the binocular vision vergence anomalies that we've already discussed. We talked about the basic exo and the basic ESO. The basic exo vision therapy would be the solution. In the basic ESO, the solution would be base out prisms. We talked about divergence insufficiency esophoria, where base out prisms for distance are the optimal solution, and divergence excess exophoria, in which vision therapy is the optimal solution. And now we're up to the last two categories. The near phoria is larger than the distance phoria. The ACA varies, and we're talking about a near disorder. And this, of course, includes convergence insufficiency, CI. It's insufficient, so the ACA is low. Convergence insufficiency means the eyes are diverged, but this is a near disorder. And so, the hallmark of convergence insufficiency is a reduced near point of convergence, a reduced NPC. And I know that a lot of times doctors tell their patients, just do pencil exercises, pencil push-ups, in order to train yourself to not diverge. And studies have systematically shown that vision therapy programs for convergence insufficiency compared with pencil push-ups, the vision therapy programs are a lot more effective. So the first solution for this patient with convergence insufficiency is vision therapy. The vision therapy exercises have been shown over and over again, especially in the CITT, the Convergence Insufficiency Treatment Trial, other publications, that convergence exercises are quite effective for this disorder. And then the last one is convergence excess. Convergence excess means that the eyes are too converged. In this case, the problem is that the eyes need to diverge. This is a near disorder with a really, really high ACA. So again, thinking about the three solutions that you can give your patient as an optometrist: vision therapy, which is mainly effective for convergence; prisms, which are best, if you put them in the glasses and they're good for all distances; and prescribing plus lenses. What would you give to this patient? I see that some of you have already written. The best solution for convergence excess is reading glasses, prescribing an addition. Because in this case, you'll put the addition in front of the patient. You'll get a lot of, when you put a plus, you release accommodation and you release accommodative convergence. So you'll get a lot of release of accommodative convergence, and the eyes will diverge in order to overcome the convergence excess. So that's the optimal prescription for convergence excess, is to give the patient a near addition. And so going back, I don't think we need to go back. I think I wrote it. Okay. So going back to what we said originally in the key points, we prescribe prisms when we see that the patient has binocular vision anomalies. Specifically, which binocular vision anomalies? Basic esophoria and divergence insufficiency. Where again, in divergence insufficiency, you have to be really careful because it's a distance disorder. And so you only really need those prisms for the distance. You don't need them for the near. So you have to think about either giving 2 pairs of glasses or giving an amount of prisms that will be good also for near, or a bifocal. The third time that we treat with prisms in the presence of binocular vision anomalies is if you have a patient who needs vision therapy. Vision therapy is the best solution for that patient, but that's not a good candidate for vision therapy. Either they live too far, they can't come to your office every week in order to do exercises, or they're just not going to do their homework, or you already tried vision therapy and it just didn't work. In that case, you're better off giving them a prism and not having them complain. So let's talk about the fourth note, or actually it was the second, but one of the key points that we talked about in the beginning. We talked about clinician discretion. We talked about verifying no prism adaptation. We talked about treating only in the presence of binocular vision anomalies. And now I want to talk about the varying approaches, the varying criteria for prescribing prisms. So let's go through the varying criteria. Now, there is no right criteria for prescribing prisms. There's actually 4 different approaches, and it's okay. You can play around and see which approach works for you, which approach works for your patient. We have the Sheard criteria, the Saladin criteria, the Percival criteria, and the associated Phoria criteria. So let's go through those. And now I need you to have your pen and pencil handy so that you can write down the calculations according to each one of these approaches. Okay, so let's go. Sheard's criteria states that in order to prescribe prisms for your patient, you need to calculate 2/3 of their Phoria and subtract from that 1/3 of the compensating fusional vergences. Now, what does that mean, compensating fusional vergences? I have an example for you here. A patient has a 6 prism diopter exophoria. They're compensating, since the eyes have an exophoria, the compensating fusional reserves are the fusional reserves that compensate for the exo. Which fusional reserves compensate for the exo? The base out reserves, because the base out are apex in, they are the convergence of the eyes. So base out reserves are the compensating fusional reserves for exophoria. So what I'm going to ask you all to do now is calculate, based on Sheard's criteria, how many prisms this patient should be prescribed. And I believe we have a poll for you that you can just write down your answer. No. No, not yet, not yet. No, don't do that, not yet. We're not there yet. So just write down what you think it might be. So we take 2/3 of 6, and we subtract from that 1/3 of the compensating fusional vergences. Now there's 3 numbers here, 6, 10, 7. 6 is the blur point. 10 is the break point where the patient sees double. And 7 is the recovery point. Which one of these numbers is the number that we take? The number that we take is actually the number 6. Why is it the number 6, the blur point? Because this is the amount of fusional vergences that are used before the visual system taps into the accommodative system. So we take the number 6 here. So we do 2/3 of 6 minus 1/3 of 6. And it comes out to 4 minus 2, which is 2 prism diopters. Okay, so 2 prism diopters is the amount of prisms that this patient needs to be prescribed. And the patient with the exophoria is prescribed based in prisms. So now we can put up the poll. The question is, what would be the new phoria if we do give this patient, we prescribe this patient 2 prism diopters base in? And the patient originally had 6 prism diopters of an exophoria. If a patient has 6 prism diopters of an exo, and you gave them 2 prism diopters base in, you've brought the item 2 prism diopters closer to the eye. If you remeasure the patient's dissociated phoria, you'll get 4 prism diopters of an exophoria, and that's the correct answer. Fantastic. Okay, now let's keep that 2 prism diopters in front of the patient's eye. And now what we're going to do is, wait, let me just put the answer up for you. Now we're going to remeasure the base out fusional reserves. So again, you're taking the patient originally had 6 prism diopters of an exo, but now the patient has 4 prism diopters of an exo because you put a prism in front of their eye. And now you're again measuring their fusional reserves, and you're measuring either with the phoropter or you're measuring with a prism bar, and you want to see what the new base out reserves are going to be. So I'm going to let you guys try to think about what the new base out convergent reserves will be. They're obviously going to change. Now, it's not that the ability of the visual system to diverge and converge has changed. No, it's about the same as what it was before. However, because you put a number, a prism, in front of the eye, it's going to change the numbers that you're measuring.
All right, so this is basically we're remeasuring the fusional versions with the 2 prism in. So
exactly.
How much is the change in divergences? And yeah, majority of them think it's 485, 46.
Okay.
Yeah.
Well, okay, so let's see what the answer is. So the new base out reserves are going to actually increase by 2. Why does that happen? Because when you put 2 prism diopters in front of the eyes and you brought the object 2 prisms closer to where the eyes really are, it appears when you're measuring with either a prism bar or with the phoropter, it appears as if your eyes are able to converge a lot more than they really are. So it appears that they're able to converge 2 prism diopters more. And so the newly measured numbers will be 8, 12, 9. However, keep in mind, I didn't put for you what the base in reserves were, but the base in reserves will also change, and the base in reserves will decrease by 2. So it's not like the total ability of the visual system to diverge and converge is going to change. It stays the same. Just the numbers are shifted according to the 2 prism diopters base in that was prescribed to the patient. Okay, so what happens once we've given the prism according to Sheard's criteria? So originally the patient had 6 prism diopters exophoria, and the base out compensating reserves were 6. Obviously, that's not a very good condition to have, because if you have a 6 prism diopter exo, that means that this is a dissociated phoria. In other words, if I close the eye, I know that the eye has a tendency to go out 6 prism diopters, which means that all day long, when the 2 eyes are working together and looking anywhere in the world, the two eyes are trying to stay straight and they're compensating for the tendency to go out 6. How do they compensate for the tendency to go out 6? They compensate by activating fusional convergence. Fusional convergence is this base out reserves, the 6 prism diopters. In other words, the eyes have a tendency to divert 6, and the fusional vergence system is able to compensate 6. That's not a very good condition to be in. Do you understand why? The eyes tend to go out 6, but that system can only compensate for 6. So all day long, that visual system is working at its most extreme case, and it doesn't have any reserves left. Can you imagine why a patient like that, that's been walking around all day long, trying to keep the eyes straight, is going to feel headaches and eye strain and burning sensations around their eyes, and basically it'll drive that patient crazy. However, if you prescribe prisms based on Sheard's criteria, you give 2 prism diopters based into this patient. The newly measured Phoria will be 4. So we've reduced the Phoria by a little bit. And the new base out reserves have increased by 2, meaning 8, 12, 9. Now look at the new situation according to Sheard's criteria. The patient has a 4 prism diopter exophoria, a tendency to go out 4, to diverge 4. But the ability of the visual system to compensate for that 4 is now 8. Meaning the fusional convergence is now 8 prism diopters. It's twice the amount of the Phoria. And so Sheard's outlook is, let me give the minimum amount of prisms to my patient that will allow the patient to have twice the ability to compensate for the dissociated Phoria. So that's what I wrote for you here. Compensating fusional reserves are twice the amount of Phoria. So that's basically his approach to how to prescribe prisms. And, there's a rule of thumb that if you have a patient and you're debating whether to prescribe prisms or not, you measure that patient's fusional reserves and the compensating fusional reserves. And if you see that the compensating fusional reserves are approximately twice as much as the dissociated Phoria, you know that patient's okay and you don't need to prescribe anything. And that rule of thumb is based on Sheard's criteria. Okay, so then we have Saladin. Saladin said Sheard's criteria is fantastic for exophoria. However, Saladin thought that for esophoria, a different approach should be taken. And so his approach is his 1-to-1 rule for esophoria. And his approach says the following. When you want to calculate how much prisms to prescribe to a patient that has esophoria, calculate half the amount of Phoria, and subtract from that the recovery point of the compensating fusional vergences. In other words, look at this case. If this patient has 8 prism diopters esophoria, and the compensating fusional vergences for esophoria are based in, meaning divergence, and that patient has x over 4 over 2, that means that 4 is the break point and 2 is the recovery point. Saladin would like the Phoria to be equal to the recovery point, and right now it's not. Take half the Phoria, which is half of 8, and subtract from that half of the recovery point from the compensating fusional vergences. So half of 8, and subtract from that half of 2, the recovery point. And what you get is 4 minus 1, which is 3 prism diopters. 3 prism diopters of base out. What is the new Phoria if I prescribe to this patient 3 prism diopters base out? Let's see if I have that as a question. Fantastic. Okay, so the new Phoria after we've prescribed 3 prism diopters of base out is now 5 esophoria. Now the question is, what are the new base in reserves? I think I have that question as well. Great. Okay, good. So the new compensating fusional reserves are now going to be measured 2 prism diopters higher, which is x over 7 over 5. Now look what happens according to the Saladin criteria. With the newly prescribed prism, the patient now has a 5 prism diopter esophoria. And with a newly prescribed prism, the base in compensating reserves are now 7/5. In other words, we've brought the phoria to the recovery point of the patient. And the approach here is, if the patient's phoria is equal to their recovery point, well, obviously that'll be beneficial for the patient, because when the system has been given some kind of blow, it's been really difficult for the visual system. We're measuring fusional reserves. We broke into diplopia. What does the visual system need in order to recover, in order to be calm again? And so if we bring the phoria to the point where the visual system is calm, that'll be a good solution for the patient. So that's basically the Saladin criteria for prescribing prisms for esophoria. So the phoria is equal to the recovery point. Okay, so far we've seen, out of 4 criteria, we've seen 2. What were the 2 that we've seen? I'm just going back to the slide that shows all 4. Okay, I jumped a little bit too much. Sheard wanted to have twice as many compensating fusional vergences compared to the phoria. And Saladin for esophoria said the phoria should be equal to the recovery point. Let's move on to the 3rd criteria, which is the criteria brought forth by Percival. Okay, so Percival's criteria says, don't even look at the phoria. Only look at the phoria in order to know what the direction of the prism is. Here, we want you to look at the fusional reserves, both convergent direction and the base in divergent direction. Those are the 2 directions in which we need to look. And then we take 1/3 of the larger number of the fusional reserves and we subtract 2/3 of the smaller fusional reserves. And by small and large, I just mean look at the base in, look at the base out, look at the first number, up to blur, and see which one is higher. Take 1/3 of the larger number and subtract from it 2/3 of the smaller number. If your calculation is negative, that means you don't prescribe prisms to this patient at all. So I have an example here, a patient with 11 prism diopters exophoria. The base out is 20/24/11, and the base in is 11/15/9. So the number that I need to look at is up to blur, which in the base out direction is 20, and in the base in direction, it's 11. And in this case, we have 20 and we have 11. 20 is the larger number. 11 is the smaller number. So we're going to take 1/3 of the 20 and subtract from it 2/3 of the 11. And what this comes out to be is a negative number. And because it's a negative number, according to Percival, we are not going to prescribe prisms to this patient. Now let's look at another case. A patient with 6 prism diopters exophoria has base out reserves 6/10/8 and base in reserves 21/26/22. Let's see if I asked you this question. No, I did not ask this question. Yeah, maybe I did. Polling
8, I think.
Question
8.
number 8. Yeah, we could put that up. Why don't you guys take your pen and paper and try to calculate how much prisms you would give according to Percival to this patient. I'm going to do it with you.
Sure.
Okay, so 1/3 of 21 is 7, and 2/3 of 6 is 4. 7 minus 4 is 3. And so we're going to prescribe 3 prism diopters of a base in. And do I have the question what the new phoria will be?
Yep, I guess.
Okay, so let's put that up. If we prescribe to this patient 3 prism diopters of base in, what will be the new phoria? So if we give the patient 3 prism diopters of a base in, we're bringing the item 3 prism diopters closer to where the eyes are. So when we remeasure the phoria, it'll only be 3 prism diopters of exophoria, as the majority have said.
That's right.
And so here's what's interesting. If I look at the fusional reserves range in the base out convergent direction, the patient is able to converge 6 prism diopters. In the base in direction, the patient is able to diverge 21 prism diopters. The total range of divergence for this patient from 21 to 6 is a total of 27 prism diopters. And I can split that entire range into 1/3, 1/3, and 1/3. How do I split it into 1/3, 1/3, and 1/3? Well, 27 divided by 3 is 9. So from 6 convergence to 3 prism diopters divergence, that's 9 prisms. So that's 1/3. From 3 divergence to 12 divergence is another 9 prisms. And from 12 divergence to 21 divergence is another 9 prisms. So according to Percival's criteria, we would like the phoria of the patient to be somewhere within the central 1/3 of the range. What happens once we've given the 3 prism diopters base into this patient? Do I have that question? Polling 10 maybe? Yeah.
Yeah.
So let's ask everybody, if I gave this patient 3 prism diopters base in, what is going to be the new fusional vergences for the patient? The base out and the base in. I gave the patient base in.
Okay,
Oh, I'm really excited because I see that a lot more people are getting it now.
yeah, I think it takes a bit of time when you get
Yeah.
to the ends of it. And
Now you see why I wanted so many questions.
yes. So first 2, 3 are just like a warm up, and then
Yes, exactly.
you get the hang on it. That's right. Okay, so I'm just gonna end this and share.
Fantastic. Okay, so that's exactly what happens. When you prescribe the base-in prisms to this patient, you're going to decrease the newly measured base-in range and increase the newly measured base-out range. By how much? Exactly by 3. So the new range, you see, instead of 21 in the base-in direction, we now have 18 in the base-in direction. And instead of 6 in the base-out direction, we now have 9 in the base-out direction. And if you remeasure the patient's phoria with the 3 prism diopters base-in, it's now a 3 prism diopter exophoria. So it's smack in the middle of the range of the fusional reserves. But not only that, there's another idea here. Now look what happens at the number of the base-out reserves and the number of the base-in reserves. You see the relationship between the base-out convergent reserves and the base-in divergent reserves? Now we've created a situation in which the base-in reserves are exactly twice the amount of the base-out reserves. So that's the idea of Percival's criteria. 2 things. We want the phoria to be in the central third of the divergence range, of the fusional vergence range. And number 2, we want the relationship between the fusional vergence to be that the smaller are half the amount of the larger. So that's Percival's criteria. The last criteria is called the associated phoria criteria. And I'll tell you now, this is the most common clinical method. Not only is it the most common clinical method, it's the most recommended method, also according to Scheiman and Wick, the Bible of the binocular vision. They recommend it because it's easy, it doesn't require any calculations, and it more closely resembles real-world conditions. What do I mean by more closely resembles real-world conditions? This is called the associated phoria, not the dissociated phoria. In order to measure this phoria, both eyes are completely open. Not only are both eyes open, there's also one target that's seen as in association, seen mutually by both eyes. So in this example, the circle is seen by both eyes. In this example, the circle is seen by both eyes. In this example, the white bar, the OXO, and the surrounding annulus are seen by the 2 eyes. In this example, the O's, the X, and the surrounding annulus are seen by the 2 eyes. So in other words, we've got a target that's seen by both the right and the left eyes simultaneously at the same time. However, there's another component to these targets that measure associated phoria. The other component is that there's also 2 objects that are seen separately by the 2 eyes. For example, here, this object is seen by the right eye, and this object is seen by the left eye. Or here in this example, the right bar is seen by the right eye, and the left bar is seen by the left eye. In this example, both the upper and the right bars are seen by the right eye, and the left and the lower bar is seen by the left eye. So in other words, we have dissociation, But at the same time, we also have a mutual binocular target. So that's why we call this real world conditions, because in the real world, we never really have a situation in which we have a dissociation between the eyes. Really, in the real world, both eyes are open at the same time. And what we do in this method is that we ask the patient, do you see the two lines as continuous? If the patient says no, we add prisms until the patient reports that the two lines are continuous. When we finish the exam, the patient has reported that the two lines are continuous, and we have a prismatic measure of the associated phoria. And that will be the amount of prism that you prescribe to your patient. Okay, so it's relatively very easy. It's just one more test. We don't have to do any fancy calculations and fusional reserves. And that's why this is the most common clinical method. Only keep in mind that if you have a mallet unit, that's good only for near, unless you purchase separately a distance mallet unit. And if you happen to have a projected chart or a computerized chart, typically those have an associated phoria target, but it's only for distance and not for near. And when you're prescribing prisms, you really want to make sure that you've measured the associated phoria in at least 2 directions. So those were all the approaches to prescribing horizontal prisms. I want to go over with you 3 approaches to prescribing vertical prisms. And the 3 approaches include dissociated phoria or parts of it, balancing fusional reserves, and again, measuring the associated phoria. And that would be, this measures the vertical associated phoria, whereas the vertical lines, they measure the horizontal associated phoria. And that's all I need to say about the associated phoria. So let's look at the dissociated phoria or parts of it. So vertical prisms, when you're prescribing vertical prisms, you can either prescribe the full amount of dissociated phoria that you've measured, or take parts of it. And different researchers recommend different amounts of parts of it. It could be 1/3, it could be 2/3, it could be 3/4, it could be nearly complete if it's larger than 1. It could be complete if the phoria is small, or you use the Krimsky method, which is prescribe the least amount that you can. The second method, the second approach, is the balancing of the fusional reserves. And here you have to calculate for each eye separately, base down to break, minus base up to break. I see that my slide got a little bit screwed up there, divided by 2. If the result is positive, you prescribe a base down. If the result is negative, you prescribe a base up. Let's see if we have this question here for you guys to calculate. Yes, we do. So we have a patient with 2 prism diopters, right hyperphoria. The fusional reserves in the right eye, supra, base down, 4/3, and infra, base up, 2/1. And the left supra is base down, 2/1, and base up is 4/3. And your question is, how many prisms should be prescribed only to the right eye? Which means you're going to take this method of calculating the balancing of the fusional reserves and calculate only based on the right fusional reserves.
All right. So I think majority of them are saying 1 prism.
Great. So it's 1 prism diopter, and it was positive, so it's base down. And I'll explain why. We take 4, which is the base down break, minus 2, which is the base up break, divided by 2. And we get 1 base down. And for the left eye, we would take the base down, which is 2, and subtract from it 4. So 2 minus 4, and that becomes a negative number. And that's why for the left eye, we would prescribe 1 prism diopter base up. So what are the new fusional reserves for this patient? Let's see if we have the question here for the new fusional reserves. We do. What will be the newly measured fusional reserves in the right eye? And the idea here is similar to what we did previously with horizontal prisms. If you prescribe base up, then the base up reserves are going to reduce and the base down reserves are going to increase. Okay, so in the right eye, the base down is going to now be 3/2, and the base up is going to be 3/2. And because of that, you see how it's almost the same numbers? So that's called balancing the fusional reserves. prescribing that prism has caused the fusional reserves in both directions, going up and going down, to be balanced in that eye. And the same is true for the left eye. And of course, the last one is the associated Phoria, and that you could either measure clinically or you can create a fixation disparity curve and extract it from that. So I'm going back to my key points. Clinician discretion. There's no set of definitive rules for when to prescribe prisms. And there's various approaches. We talked about various approaches for horizontal prism and various approaches for vertical prism. But it's clear that you have to verify that there's no prism adaptation, no prism Vergence adaptation before you prescribe a prism to your patient. And you only treat in the presence of binocular vision anomalies. But last, but most important, you only treat when indicated. Do you know that expression in America, if it ain't broke, don't fix? If something's not bothering your patient, there's no reason to prescribe prism. We only prescribe prism when the patient comes with astinopia. So what are points to consider when prescribing prisms? First of all, keep in mind Prentice's rule. Every prism diopter is equal to the dioptric power of the optical lens times the decentration in centimeters. So you can actually get a prismatic effect by doing decentration, with respect to the OC of the glasses without actually prescribing prisms that are ground in. Another thing to consider, if you're going to be prescribing prisms on a bifocal, we have slab off, which is base up prism, and we have reverse slab off, which is a base down prism. We typically put the base up prism on the most minus or least plus lens. And the idea is that we do that in order to even out the thickness. We don't want something to be extra super thick in a particular direction. If you do a reverse slab off, which is a base down, you put that on the most plus or the least minus lens, again, to even out the thickness. Contact lenses. Well, this is an interesting one. If you have a patient that really doesn't want spectacles and really needs prisms, well, what can you do? Can you help that patient? Well, if you could prescribe vision therapy, try to do that. But if you can't help with vision therapy and you can't help with an addition lens, what can you do for this patient in terms of contact lenses? So this is a hard one because every time you blink, the contact lens kind of rotates in the eye, and we need to find a method to stabilize the eye so that the prism is always in place. And the manufacturers really don't like to put prisms inside contact lenses because it makes them really thick and it makes it very difficult for the patient to handle the lenses in their eyes. So only small amounts can be prescribed and basically only base down. Can you think about why only base down? So only base down because that way it's thicker on the bottom. And so when you blink and the lens is rotating, it'll rotate back so that the thick part is on the bottom. In fact, for toric lenses, using thin zones and prism ballast is a well-known contact lens stability method. So for that reason, base down is basically the only type of prism that can be prescribed in a contact lens. Well, is it really the only type? While I was preparing this talk, I found this case report, treatment of horizontal binocular diplopia with prismatic contact lenses. And they did this with one case in which they created custom 3D printed sclera lenses, which allows horizontal prisms ground into the contact lenses. I actually consulted with one of the manufacturers. We have a Cooper Vision here in Israel, and I consulted with them about the prisms, and they told me that it can't be done. And then I sent them this paper, and they were like, wow, we didn't even know that could be done. So you should know that it's in the works, and at some point in the future, it will be possible to put other types of prisms, at least on sclera lenses. Other points to consider: commitancy. Commitant deviations are deviations that are equal in different directions of gaze. Non-commitant deviations differ in the different directions of gaze. In these cases, where you have differing amounts of deviations in different directions of gaze, it's a problem because you don't know how many prisms to prescribe. Do I prescribe based on the downwards gaze? Do I prescribe based on the upwards gaze? Do I prescribe based on the straight ahead gaze? And what about when the patient's looking to the right and left, if there's an incompetency? So the most successful prismatic treatments are ones given to comitant deviations. In other words, deviations that are equal in different directions of gaze. Other uses for prisms that I didn't describe earlier are for head tilts. If you have a patient that walks around like this all day, so that can cause neck pain, and that can be really cumbersome and uncomfortable for the patient. Why is the patient walking around like this all day with the chin up tilt? Because bringing the chin up makes the eyes go down in the socket. And that means that the patient has less diplopia and has a more comfortable feeling throughout the day when their eyes are looking down. So let's help them. Let's give them a base up prism in both eyes, yoked prisms in both eyes, so that the images go down. And that way the patient doesn't have to tilt the head. They can keep the head straight and see the object where it's most comfortable for them in the lower visual field. Appearances. Prisms are really ugly. It's really not aesthetically pleasing to have prisms in the eyes. We try, it's also very heavy. And they also distort. So we like to prescribe prisms only up to 10 prism diopters in the spectacles. Otherwise, you may want to combine contact lenses and the prisms, or you may want to recommend surgery. We try to split it up between the two eyes, half-half. That way, aesthetically, it looks equal in the two eyes. And one last thing that I want to finish off with is a sample case. So I brought for you here a 12-year-old girl. The Von Graf distance dissociated measure of the Phoria is 15 prism diopters esophoria. The near dissociated Phoria is 2 prism diopters esophoria. She complains of intermittent diplopia at distance and headaches. Her base out fusional range at distance is 13/11, and her base in range at distance is 12/7. Her refraction and best corrected visual acuity in the right and left eyes are, look, I wrote OD twice, oops, are -1. And what is the diagnosis and the recommended treatment? And I think I have that in a poll for you. Last case for today.
Majority says divergence insufficiency and skewness between.
Okay, so let's see. So we see that there's a high distance esophoria and a low to normal near esophoria. We see complaints at distance. So obviously this is a distance disorder. So it's a divergence something. The base in range is low. We also see that the patient has a simple myopia. So this is divergence insufficiency. And the recommended treatment for divergence insufficiency, I think that was the second question, but that's okay, is base out prisms, because it was one of the examples that we gave for treating patients with binocular vision disorders. And so now I have a question for you. If I want to diagnose this patient, I want to give the patient prisms. How many prisms do I give this patient? So I have a few options here, right? 4 options. I could do it according to Sheard's criteria. And according to Sheard, what I do is I take 2/3 of the Phoria and subtract 1/3 of the compensating fusional reserves. So compensating fusional reserves is the base in, and it's 5. So 2/3 of 15 is 30 divided by 3. I subtract from it 5 divided by 3, and I get 25 divided by 3, which is approximately 8 prism diopters base out. The new Phoria with the 8 prism diopters base out will now be 7 prism diopters esophoria. What will be the new base out range and the new base in range? Well, we're going to prescribe 8 prism diopters base out. That means we're reducing the base out by 8 prisms. So it'll be 15/8. And we're increasing the base in range by 8 prism diopters. So the new base in will be 13/11. Now note what happened. The new Phoria is 7 esophoria, and the compensating fusional reserves are twice the amount of Phoria, just like Sheard's criteria. Our second criteria are Percival's criteria. Here we take 1/3 of the larger amount of fusional reserves, subtract from it 2/3 of the smaller amount of reserves, so 23 divided by 3, minus 10 divided by 3, and we get 4.5 prism diopters of base out. The new Phoria will now be 11.5 prism diopters of esophoria. The new base out will now be reduced by exactly 4.5, so 18.5, and the new base in will be increased by 4.5 to 9.5. Now look at the numbers here. The base in is half the amount of the base out, just like Percival's criteria. According to Saladin, Saladin says, use me for esophoria. And Saladin says, let's bring the phoria so that it's equal to the recovery of the compensating fusional reserves. So what do? We take half the phoria and subtract from it the recovery of the compensating fusional reserves divided by 2. So 15 divided by 2 minus 3 divided by 2 comes out to 12 divided by 2, and it comes out to 6 prism diopters base out. The new phoria will now be 9 prism diopters esophoria. The new base out will now be decreased by 6, so it'll be 17 over 10. And the new base in will be increased by 6, 11 over 9. Now we've brought the new phoria so that it's equal to the recovery. And of course, your last option is to measure the associated phoria, and based on that, give prisms to your patient. So that was it. That was my talk about prescribing prisms. I hope that I made it a little bit more accessible for you, and happy to take any questions if you have.
Okay, so thank you so much, Dr. Gantz, for that wonderful talk. I think you kept us awake for the whole 1 hour, 25 minutes. I think we were on our books, paper and pen, and trying to solve and getting out the answers. Thank you so much.
So the first question that I was asked is, in the last case study that I brought you guys, what would be the approach I would take to prescribing the prisms? Which is a really good question, because we got 3 different numbers here, and it's only 3 that I've shown, right? Because if you were to measure the associated phoria, you'd get something else. So my approach is always, and again, this is me. It doesn't mean that I'm doing the right thing, because the first thing that came up in the review paper that I put up originally is that it really is up to the clinician's discretion. The clinician needs to find the right method for them. There's no real right answer. Yes, I would do the associated phoria, but knowing me, I'm very meticulous. I would probably also calculate all the different approaches and try to see if, there's 6, there's 4.5, and there's 8. I really like to keep prisms to a minimum. So I would probably, look at what the associated phoria was and see if 4.5 is closer to it.
Okay, great. So
if a patient is new to 8 prism diopters, based out, and it's difficult to tolerate, what would we do? So that's why my approach is always to give the minimum. Yeah. And, you bring your patient back, right? You have to do a follow-up. Approximately a month after you prescribe the prism, bring them back, see how they're doing. Make sure that you did a great test of prism adaptation and that they haven't reverted back to their previous phoria. And if you see that they're happy after a month, bring them back after 3 months. And then again after 6 months, just to make sure that they're okay. It's possible that 8 would feel like it's too much for this patient. And you would know that if you gave them the prism and had them sit outside for 20 minutes, kind of walk around, read some text with it. You want to also ask them about their subjective impression. So you might get a sense from your own patient that 8 is a little bit too much, and you might want to go down. And I agree 100% that it has to depend also on the patient's comfort, which is why it's so important to put that prism in the trial frame and have them sit outside and wait. Wait, there's a few questions here. Hold on, let me keep track. What is the appropriate testing distance for distance associated phoria? So whatever the distance is that you're doing your visual acuity measurement on your patient. So I don't know if you guys work at 3 meters with a mirror, or you have an exam lane that's 4 meters or 6 meters. I would keep the measurement of the associated phoria to be the same measurement that I measure the refraction.
Okay.
Another question is, in prism adaptation, will remeasure the deviation after prism adaptation applicable for all cases? 100%, yes. Don't give up on doing that. It's so important for 2 reasons. First, to tell you if this is a patient that's going to swallow prisms, because you might prescribe 4, okay? And then they come back a month later and you need to again prescribe, and now 4, now 8, it'll keep increasing. The patient's going to, we call it swallow the prisms. That's number 1. Number 2, don't forget, just like a previous respondent wrote here on the chat, it's so important to get your patient's feedback. and how they feel with a prism. So doing this Vergence Adaptation test, you're actually killing two birds with one stone, because not only are you examining if the patient is going to swallow prisms, you're also examining how your patient feels with a prism in the trial frame. And that's why it's so important.
Yeah, that's right. And you did also mention that let them walk around your practice and, get that adaptation into it. Don't just...
Yeah, and not just in the practice, also go outside the practice. I know it's a little bit embarrassing to walk around with a trial frame, but it's so important to see how they're managing in their everyday life, as they're walking around. Obviously, you're not going to have them drive with it, right? But have them walk around, if it's possible, in the clinic area, and for more than 2-3 minutes. It's not like how you buy new shoes and you always tell your kids walk around in the shoes, but sometimes you walk around in the shoes in the store and it feels fine, and then you wear it for a full day and it kills you. So really give them that 15 to 20 minutes.
Okay. And
in CE cases, I suggested adding plus lenses. Yes. Do I wean off that? I would only wean off that if I felt like that patient is improving in their ability to diverge. If I don't feel that the patient is improving, and I can easily measure that with fusional reserves, right? So I can measure their fusional reserves each time they come back for checkups. And if I see that it's improving, then definitely I can start weaning them off. And I would wean them off based on their ACA and their measured divergence.
Okay.
So if there's an concomitant deviation, can we prescribe prisms, and then how much? I'll tell you, it's tricky, but I would check how much it is in the different, you would measure 9 directions of gaze, see how much the prism is in the 9 directions of gaze, and see what the least common denominator is for the 9 directions of gaze, and see if that's helpful to your patient.
Okay. And I'm just seeing the chat if there are any more. Yep. And which is the best way to measure the Phorias? I mean, do you prefer loose prisms, or do you prism the phoropterin? Is there anything which we should do? Because not everyone would have both the tests available probably. So which one do you think?
Just do cover test.
Cover test.
Right? It's cheap. It's available. You can do it easily in any place. So yeah, just do cover test.
Okay.
So easy. But one thing that is important to state, whatever method you find most convenient for you for measuring dissociated phoria, keep measuring with that same method on that patient. Because otherwise, when you measure with different types of techniques, you always get different results. So you want to make sure you're using the consistent method all throughout.
That's right. So on every follow-up, if you had measured using X technique, use that same technique for all your follow-ups, and making sure that the prescription works for the patient, right?
Exactly.
Right. And the follow-up schedule. So I understand you did mention you want to see the patient after 1 month. So is that true for all the amounts of prism, or probably the higher amounts you want to see them earlier? Or is it standard?
I would actually bring every patient, based on their availability and your availability. I would like to see a patient with a prescribed prism back after a month, then again after 3, and then again after 6. Now, if you feel like you're very confident after a month that you've prescribed the correct prescription, also based on your patient's, your patient's subjective experience, you may want to tell them, okay, don't come back in 2 months. Come back, in 5 months. Let me see you again at the 6-month checkup.
Okay, great. And there's one question as for DI cases.
Divergence and deficiency cases, prism prescription was suggested for distance. Okay, so Fresnel prisms. Yeah, that's a really great idea. Just like you would do a bifocal and you would only prescribe the prism for one distance. So that's definitely an option. I'll tell you when Fresnel prisms are most commonly used. They're commonly used if you have a deviation that's going to pass, like if it's secondary to diabetes or trauma, then you would give a Fresnel because you know that it's temporary and it's easy to remove.
Yeah.
Number 2, you use Fresnel when you want to forecast whether strabismus surgery is going to be successful. So you may want to have that patient wear a Fresnel prism until the surgery to see that it's okay. But I would be hesitant to prescribe a Fresnel prism unless my patient has no money and can't afford it and is seeing diplopia, and then I would definitely do the Fresnel, because the problem with a Fresnel is that there's a lot of aberrations. It's really hard to get a good view as opposed to like a single prism.
Okay.
Oh, is there a specific protocol for torsional diplopia? Yeah, I didn't even mention that, right? So yes, there's, do you know the double Maddox technique, the double Maddox test? So that would be the, gold standard test to use if you want to manage torsional diplopia. And then you could just do with the subjective, have the patient turn around in the trial frame, the two Maddox rods until they see an X, and then you know exactly the angle of the deviation. And you just put that down for the manufacturer, and they already know to figure out what vector to calculate for your prisms. Another option is to measure separately the horizontal and the vertical. We usually do vertical first and then horizontal. Like we eliminate the vertical with correction, and then we measure the horizontal. And then you could send that to the manufacturer, and they will calculate for you what the vector, what the angle of the appropriate prism is.
Yeah. So that would work in the cases where patients would have both vertical and horizontal prism requirements. So you would give a vector. Right?
Exactly. Of computer laptops during work from home or online due to the pandemic can actually measure affect Phoria and fusional vergences. Well, that's an interesting question. And, I haven't looked at it, and I'm not familiar of people who have looked at it, but here's what I am familiar with. There's been a lot of studies done on digital eye strain where they compare binocular visual outcome measures before and after 1 hour of work on a computer, and definitely you see an effect on the Phoria.
Mm-hmm.
So my answer to you would be yes, I 100% think so. And I do have one interesting thing to add that's not related to Phoria and prisms. During the pandemic, there's a digital eye strain questionnaire that's been validated and used in several studies. And so I gave out that questionnaire in my college to college students, and I have responses from 180 students from institutions from around Israel. I also have responses from something like 180 or 200 optometry students at SUNY, because I did it together with a colleague at SUNY. And we found a very high increase in symptoms of ocular strain during use of computer monitors. Something between 30 to 40% of our respondents, and I'm talking about young students, 30 to 40% complained of different types of symptoms of ocular eye strain. And then we had them fill out the ocular surface index disease, dry eye index, because we were thinking, if they have dry eye, obviously they're going to have complaints. So the prevalence of dry eye in that sample was a lot lower than the prevalence of the symptoms due to digital eye strain. So we definitely see an increase in symptoms due to the increase in online classes due to the pandemic.
That's right. Okay. So I think more work.
But that wasn't really an answer to your question, was it?
That's right. Yeah, but I think we need more evidence. It's too soon to tell, and we need to look at more of research in that particular area.
So here's my good news to you. In my country, we're slowly getting out of the pandemic. Like I realized before I went outside and I didn't put on a mask, and I was like, oh, we don't have to do masks anymore. So really slowly, we only had 100 cases of COVID today.
Okay.
And also yesterday and the day before that. So we've really basically over 55% of the population is twice vaccinated, and we're starting this month to vaccinate our 12 to 14-year-olds. So yeah, we're slowly going back. And what's my idea? That as soon as we go back to frontal learning, I want the same people who filled out my questionnaire last year during the school closures to fill it out once more, and then we can compare.
Yeah, then we could get a very appropriate answer to that question.
That's right.
Okay, so I think with that, thank you very much for that kind answers and sharing your experience. I think really important, because when it comes to prism prescription, a lot of us, as we saw in our second poll, many of us were not probably confident in prescribing prism, if I may put it that way. And with all that experience and the discussion today, I think we would be better off at least calculating and coming out with some prism prescriptions and trying onto our patients. Great.
The vaccine that's approved for our teens is the Pfizer one, where they're waiting for FDA approval in the US, and then they're going to start rolling it out here.
Okay, great.
And I also want to just share, my thoughts and my prayers with all the people in India and all the other countries that are still in the midst of a terrible, terrible outbreak of COVID. So I wish everybody lots of health.
Yeah, thank you so much. I think prayers are with every one of us. I think difficult times, but then hopefully prayers are something which will get us all back all together, right? Okay.
Right.
So thank you everyone for attending today's session. Thank you so much, Dr. Gantz, for that wonderful talk and sharing your experience as well.
Sure. Thank you. Thank you so much for inviting me.
Most welcome. So we do have session planned on next weekend, and I hope to see you next week. Until then, take care, be safe, and see you next week. Bye-bye.